My name is Cindy Yo. I'm an associate attending in the Department of Anesthesiology and Critical Care Medicine at Memorial Sloan Kettering Cancer Center. The topic of today's ASRA webcast is caring for transgender patients in the perioperative period. We will start with some background information on transgender patients. The transgender community is the most marginalized and underserved population in medicine. Recent studies estimate 25 million people worldwide who identify as transgender. Of these, 1.4 million reside in the United States. With increasing visibility, education, and acceptance within our societies, more transgender patients will present to our medical settings, and it is therefore imperative that healthcare providers develop cultural competence and acquire knowledge and skills in order to safely manage these patients. In order to serve these patients well, we must first familiarize ourselves with important terminology. Sex refers to sex assigned at birth. It is based on assessment of internal and external sex organs, chromosomes, and hormonal activities within the body. Gender, however, is socially, culturally, and personally defined. It includes how individuals see themselves, how others perceive them, and their interactions with other people. Gender as binary, that is, male or female, is a concept that has dominated Western societies. This has been enforced and maintained by mainstream media, religion, education, social, cultural, and political systems. However, many cultures worldwide, such as the Navajo and Samoan cultures, do not actually conform to such a binary paradigm. A societal shift to define and appreciate gender on a continuum actually frees individuals to be authentic both in their gender identity and expression. Because of this, it has given rise to an array of terms to define one's gender or genders, and this continues to vary and evolve. Here we have a table on gender classification definitions. A cisgender person is someone whose gender identity matches his or her sex at birth. A trans male is assigned female at birth but identifies as a man or somewhere on the masculine spectrum. A trans female is someone who is assigned male at birth but identifies as a woman or on the feminine spectrum. A gender nonconforming individual is someone whose gender identity differs from that assigned at birth. However, it is more complex and less clearly defined than that of transgender persons. A non binary individual identifies as neither male or female. Someone who is transitioning is merely in the process of developing gender expression to match their gender identity. And finally, transsexual individuals are transgender persons who have sought medical attention. So, what are the barriers to healthcare experienced by transgender patients? Personal barriers refer to transgender stigmas, a sense of inferiority and powerlessness that society may subconsciously assign to this marginalized group that could prevent them from seeking medical attention even when it is needed. Structural barriers refer to obstacles faced at institutional levels, such as healthcare systems and insurance policies, that may hinder access to quality healthcare. Fortunately, laws exist to make healthcare discrimination against this patient population illegal. Despite this, transgender patients are still less likely to have health insurance compared to their cisgender counterparts. And even with laws in place and access to healthcare, do transgender patients have the same high quality healthcare as cisgender patients? Transgender patients report that lack of providers with expertise in transgender medicine actually represents the major obstacle to quality healthcare. And this is attributed to medical school and residency curricula that is still just barely catching up in terms of transgender specific health needs. In addition to familiarizing oneself with the terminology and understanding some of the barriers that these patients face, we need to also be familiar with gender affirming therapies. Behavioral modification refers to techniques such as genital tucking, which is pushing of testes into the inguinal canal, packing, which is placing of a prosthesis in one's underwear, and chest binding, which refers to methods of flattening of breast tissue. Psychotherapy is aimed at treating dysphoria and any associated symptoms such as anxiety, depression, fear, guilt, low self esteem, and even self hatred. It is not treatment of the gender identity itself. Medical management refers to hormone therapy. In the case of feminizing hormone therapy, the goal is development of female secondary sex characteristics and suppression of male secondary sex characteristics. Therapy consists of estrogen, progesterone, and anti-androgens. For masculinizing hormone therapy, the goal is the opposite, and treatment consists of different forms of testosterone. An increasing number of patients are presenting for gender-related surgical management in their final stages of gender transition. Male to female surgeries include breast augmentation, also known as top surgery, removal of male genitalia with construction of female genitalia, such as vaginoplasty and clitoroplasty, also known as bottom surgery, non-genital, non-breast surgeries, such as thyroid cartilage reduction and voice surgeries. Some trans males choose to retain their uterus and ovaries, while others have them removed. This obviously impacts any future fertility options. Female to male surgeries include bilateral mastectomy, also known as top surgery, removal of female genitalia and creation of male genitalia, known as phalloplasty and scrotoplasty, also known as bottom surgery, and non-genital surgery like voice surgery and liposuction. Now that we are armed with the background that we need, let's move on to the meat of the lecture: the preoperative care of the transgender patient. A large proportion of these patients report harassment or violence in the medical setting. It is imperative that the physical healthcare environment should be prepared to feel welcoming to these patients. All healthcare staff should be educated to be familiar with transgender terminology and specific health issues of these patients. The patient interview should include specific details on transgender status, transition history, hormone use, inventory of organs, and gender-related surgeries. The physical exam should be relevant to anatomy that is present, regardless of gender presentation. Assumptions to the anatomy or identity of the patient must always be avoided. A chaperone should always be present during the physical exam, and the gender of the chaperone should be decided upon by the patient. It is also important to note that secondary sex characteristics may be present along a spectrum of development in these patients on hormone therapy. Appropriate lab testing is important in the preoperative process because it helps stratify risk, directs anesthetic choices, and guides management. The effects of hormone therapy on a patient's blood chemistry can vary depending on drug and duration of therapy. Hormone therapy tends to decrease hemoglobin and hematocrit and creatinine levels in transgender women, while increasing it in transgender men. Additionally, one will note a decrease in calcium, albumin, alkaline phosphatase in transgender women, and increased triglycerides and decreased HDL in transgender men. In accordance with ASA Practice Advisory for Pre-Anesthesia Evaluation, pregnancy testing must be done for all biologic female patients of childbearing age, as results would alter the patient's medical management. It is important to highlight and underscore that this rule extends to transgender men with intact female reproductive organs. Transgender men with intact female reproductive organs have successfully conceived and carried a pregnancy after using testosterone. And transgender men have also had unintended pregnancies while amenorrheic from testosterone therapy. This was previously thought to preclude pregnancy. And here we have a table illustrating the changes in lab values for transgender patients on hormone therapy. This was adapted from Considerations for Transgender Patients Perioperatively that was recently published in Anesthesiology Clinics by Talinci et al. Now that we know what to expect in terms of changes in lab values for patients on hormone therapy, we're going to move on to the preoperative risk assessment by organ system. Sex is an independent predictor of cardiovascular health outcomes. Transgender women receiving hormone therapy tend to have a higher prevalence of myocardial infarction and cerebrovascular disease. They have greater than twofold increase in the rate of MIs compared with cisgender women, but no significant increase when compared with cisgender men, even after we've adjusted for cardiovascular risk factors. Transgender men, however, have a twofold increase in the rate of MI compared with cisgender men, and a fourfold increase compared to cisgender women. Moving on to the pulmonary system, there is insufficient literature regarding long-term health effects of chest binding techniques in this patient population. However, negative short-term physical symptoms have been reported, and these range from shortness of breath to chest pain and rib fractures. In the preoperative period, it is therefore important for providers to clearly explain to these patients that chest binding is not recommended in the perioperative period so as to mitigate any pulmonary derangements from their use. While the effect of hormone therapy on the disease course of diabetes mellitus is unclear, studies have indicated that transgender men and women tend to have a higher prevalence of type 1 and type 2 diabetes compared to their cisgender counterparts. These have been shown to be related to modifiable risk factors of high triglycerides and HDL cholesterol. Current recommendations for screening and management do not differ from existing national guidelines. As we continue to discuss the preoperative risk assessment of the transgender patient, here is an illustration that should help us remember some of these predisposing risk factors. Having discussed the heart, the lungs, and the endocrine system, let's move on to infectious disease. HIV has a high prevalence in the transgender community. Perioperative risks to be considered and addressed in the preoperative period for patient optimization should include HIV-associated coronary artery disease, cardiac and hematologic abnormalities, pulmonary hypertension, and hepatic and renal dysfunction. Hematologic considerations include higher rates of venous thromboembolism in the transgender woman due to hormone therapy. Proposed recommendations to reduce the risk of VTE in transgender women include stopping hormone therapy 2 weeks before major surgery and then resuming it after 3 weeks of full mobilization. Unfortunately, conflicting evidence on the benefit prevents this from becoming standard guidelines. If necessary to continue with hormone therapy, transdermal preparations have been deemed safer than oral preparations of estrogen and should be considered. Some recommend 81 milligrams of aspirin as a preventative measure, especially in transgender patients who are smokers. Last but not least, transgender patients often struggle with mental health issues such as depression and anxiety as a consequence of gender dysphoria, and it is very, very important to address these mental health issues early in the preoperative period. Having conducted a thorough and complete preoperative assessment of the transgender patient, we will now move on to the intraoperative care and concerns. Major intraoperative concerns include VTE, venous thromboembolism, and pulmonary embolism. While these hematologic events are related to immobility during surgery for all patients, transgender patients are at greater risk because of their hormone therapy. Rates of VTE as high as 6% have been reported for transgender women on estrogen therapy. Additional risk factors such as smoking, hypercoagulable disorders, cancer, and length of surgery should also be considered, and therefore VTE prophylaxis with sub-Q heparin and sequential compression devices are essential. To date, there are no documented drug-drug interactions among current forms of hormone therapy with anesthesia medications. Hence, administration of anesthetics should proceed according to standard practice. For anatomical considerations, this is of particular importance for transgender patients who have undergone gender-confirming surgery. For example, Foley catheter placement may be more challenging in patients who have had vaginoplasty, phalloplasty, or urethral lengthening procedures, and consultation of urology for bladder catheterization may be appropriate. In the transgender woman who has had laryngoplasty or chondroplasty to alter the pitch of her voice, attention to details such as a history of vocal cord damage, tracheal stenosis, and even dysphagia is important as it may necessitate caution during intubation. Transgender patients experience higher rates of HIV infection, as previously mentioned. It is therefore important to continue to be vigilant of increased cardiovascular, pulmonary, renal, and hepatic risk associated with HIV infections, which can often impact the intraoperative course. While the cardiovascular risk associated with testosterone therapy in cisgender men are not well understood, parenteral testosterone is associated with increased hematocrit, higher blood viscosity, and increased rates of stroke. Hence, pre-existing coronary artery disease and testosterone therapy warrants careful consideration intraoperatively, and appropriate monitoring to prevent cardiovascular complications should take place. Postoperative care of the transgender patient, the final stage in our perioperative management. The post-anesthesia care unit is a busy, high-traffic area. It is accessed by many healthcare providers, and patient privacy is therefore limited, and healthcare providers should avoid having discussions that can be overheard by patients and staff who are not involved in the care of these patients. While this principle applies to all patients, it is of particular importance to the transgender population because of concerns over discriminatory healthcare treatment. Transgender patients should be roomed in accordance with their gender identity. If the medical record does not accommodate sex and gender as distinct values, communication is key to ensure that staff involved in the care of these patients are aware of any intentional discrepancies. If available, a private room should always be offered as an option, and it is important to engage in these conversations early on. As previously mentioned, transgender patients have higher rates of mental health issues such as anxiety and depression. Mental health issues may be exacerbated by surgery and prolonged hospital stays. Therefore, early consultation and a multidisciplinary team approach that involves mental health, social work, physical therapy, and spiritual care often yields the best result for the recovery in these patients. Last but not least, pain management is of great importance during the postoperative period for these patients. Some contributing elements to postoperative and chronic pain include psychological factors, medical factors, and a complex history of previous surgeries and an impaired immune system. Therefore, a multimodal approach that includes non-pharmacological therapy should be used while being cognizant of a higher drug addiction rate in these patients. To conclude, in order to best care for this marginalized and underserved patient population, it is critical that healthcare systems provide easy access to medical care for these patients. It is important to make available streamlined coordination of necessary subspecialty services to facilitate their care and to promote their recovery from surgery. The information presented in this lecture is merely an introduction to caring for transgender patients. Salient points at each stage of the transgender patient's perioperative course was discussed. While this lecture is a good starting point, I encourage you to delve deeper on this topic. Educate yourself and others, because the onus is ultimately on ourselves as healthcare providers to be prepared with knowledge so that we can provide quality medical care to the transgender patient population. Education and training of healthcare providers is critical in order to meet the specific healthcare needs of this patient population. This needs to begin early in medical school and residencies to allow for adequate coverage of transgender healthcare topics and to address cultural competency and standards of care for these patients. Thank you.